steroid. Steroids, vasoconstriction, purification, healing soft solutions, scientists to that. Oxygen healing plus oxygen, the ratio 70:30 is given. It's a 2-year-old distinction. Steroids, hydration, fluidification, Helios, Helios is 70s to the here you will get steroids, hydration, most common granulomatosis condition of the larynx is TB larynx that occurs secondary to primary TB. Most common part of larynx affected in TB is posterior part. Most common part of larynx affected in all other infections except TB is anterior part. Tuberculosis, most common granulomatosis condition of larynx. Most common granulomatosis condition of larynx. It occurs secondary to primary TB. Granulomatosis condition of larynx secondary to primary TB. TB posterior part all other infections it is anterior part. Presenting features of TB larynx is severe fever, malaise, cough, very painful image. TB is usually a painless condition. Except TB larynx, very painful condition. TB larynx is a painful, it's very painful condition. It's the TB larynx. Mammaliated arytenoids. First part affected is the arytenoids, mammaliated arytenoids, mouse-lingual vocal cords, turban epiglottis or pseudoedema. Turban epiglottis or pseudoedema, mouse-lingual arytenoids. Turban epiglottis or mammaliated arytenoids. Mammaliated arytenoids, turban epiglottis or pseudoedema and mouse-lingual vocal cords. Mammaliated arytenoids, mouse-lingual vocal cords. Congenital conditions of larynx. Most common congenital most common congenital So most common congenital anomaly is laryngomalacia. Second most common is vocal cord palsy. Third most common is glottic stenosis. Laryngomalacia. Either at birth or a little later. In laryngomalacia, anticipated at this person. So laryngomalacia and epiglottitis. Decreases while sleeping, oral feature is absent. Signs of respiratory distress is absent. Signs of respiratory distress and cyanosis are absent. Signs of respiratory absent. Signs of respiratory distress and cyanosis absent. Epiglottis is enlarged, curled up, omega shaped. Any epiglottic fold is short and floppy. Arytenoids are enlarged. So epiglottis is enlarged, curled up, omega shaped. Enlarged, curled up, and fold is enlarged. Every epiglottic fold is enlarged, Every epiglottic fold will be short and floppy. Arytenoids are enlarged. Any epiglottic fold is short and floppy. Arytenoids are enlarged. Excessive lax tissue. Excessive lax tissue. Management is basically conservative. It disappears by 2 years of age. If persistent, it is due to excess of lax tissue, and if required, you have to use supraglotoplasty. Supraglotoplasty has to be done. Third most common congenital. Third most common congenital anomaly of the larynx is subglottic stenosis. Because subglottic diameter in full term is less than 4 millimeters. In preterm, it will be less than 3 millimeters. This is termed as congenital subglottic stenosis. Subglottic diameter in full term will be less than or equal to 4 millimeters. In preterm, it will be less than 3 millimeters. It can also be acquired. Most common cause of acquired subglottic stenosis is prolonged intubation. This can be prevented by shift to tracheostomy after 2 to 3 weeks. Shift to tracheostomy after 2 to 3 weeks. History of prolonged intubation should be noted. History of prolonged intubation should be noted. Persons with biphasic stridor. Best investigation is rigid endoscopy, graded by Mayer Cotton grading. Most common congenital anomaly of larynx is subglottic Most common cause of acquired subglottic stenosis is prolonged intubation. This can be prevented by shift to tracheostomy after 2 to 3 weeks. History of prolonged intubation should be noted, which presents with biphasic intubation. History of prolonged intubation should be noted in persons with biphasic stridor. Biphasic stridor, because we have subglottic stenosis, right? Subglottic stenosis is biphasic stridor. Best investigation would be rigid endoscopy is the best investigation for subglottic stenosis. It is graded stenosis. Subglottic stenosis is graded by Mayer Cotton grading. Mayer Cotton grading is used for subglottic stenosis, where there is no subglottic stenosis. It is graded by Mayer Cotton grading, and we use presence with biphasic stridor. Mayer Cotton grading was used, right? Mayer Cotton grading was used, and there is no obstruction to 50% obstruction, 51 to 7. No obstruction to 50%, 51 to 70%, 71 to 99%, and then you have no detectable movement grade 1. So Cotton Mayer grading of subglottic stenosis is grade 1, 2, 3, 4, right? So grade 1 will be 0 to 50%, 50 to 70, 51 to 70%, 71 to 99%. No detectable movement. Now management depends on grading. If you have grade 1, there will be no management. Grade 1 will be no management is required. And grade 2 and early grade 3, graft is placed posteriorly. Most common costal cartilage graft. Grade 3 and grade 4, graft is placed both posteriorly and anteriorly. Graft is placed posteriorly. Graft is placed both posteriorly and anteriorly. Grade 4. If symptoms does not subside, cricotracheal resection. In early and immature cases, you can do balloon dilatation. To prevent restenosis of subglottic stenosis, we will use mitomycin C. Stent is placed called as Montgomery tube. It gives support, prevents restenosis following surgery. Also used for respiration. It is also used for respiration. Right? So subglottic stenosis grade 1, no management. No management. Grade 2 and early grade 1, we will use graft, which is costal cartilage graft placed posteriorly. Okay. Here both of these things, graft placed anteriorly and posteriorly. And then we will also use mitomycin C to prevent restenosis. Montgomery tube is the stent which is placed. It prevents restenosis following surgery. It is also used for respiration. Laryngeal web is caused due to incomplete recanalization of larynx during development. Laryngeal web is placed due to incomplete recanalization of larynx during development. Most common site is anterior part of glottis. We cry. Incomplete recanalization of larynx during development. Laryngeal web is formed due to incomplete recanalization of larynx during development. Anteriorly, you will have most common site of laryngeal web is the anterior part of larynx. Most common site of laryngeal web, anterior part of glottis. Anterior part of glottis is the most common site of laryngeal. Anterior part of glottis is the most common site of laryngeal web. And you can also have a weak cry. Stridor can be inspiratory or biphasic. Stridor can be inspiratory or biphasic. Diagnosed by endoscopy. Management is excision with a knife or laser, which is carbon dioxide. Excision with a knife or a laser. Excision with a knife or a laser. Laryngeal keel prevents adhesions after surgery for 2 weeks. Laryngeal keel prevents adhesions after surgery for 2 weeks. So cause would be due to incomplete recanalization of larynx during development. Excision with knife for carbon dioxide laser. Child with biphasic stridor and lesion on face. There's a child with biphasic stridor and lesion on face. Suspect and rule out subglottic hemangioma. It may be localized to one part or maybe a large hemangioma. Management first line is propranolol. Steroids injections, submucous resection by laryngofissure, carbon dioxide laser. They may involute and disappear by 5 years. If not, management remains the same. So child with biphasic stridor and lesions. Child with biphasic stridor and lesions on the face. Child with biphasic stridor and lesions on the face. First you have to rule out a cavernous hemangioma. It may be localized to one part or maybe a part of a large hemangioma. Management would be first line for cavernous hemangioma. You would give propranolol followed by steroid injections. Submucous resections or laryngofissure. So propranolol, steroids, submucous resection or laryngofissure, carbon dioxide laser. They may involute and disappear by 5 years. If not, management remains the same. They may involute and disappear by 5 years. If not, management remains the same. Submucous resection is laryngofissure. Carbon dioxide laser. Then involute and disappear. Recurrent respiratory papillomatosis, acquired condition of bimodal age occurrence. It is caused by human papillomavirus, strains 6 and 11. Adult is pre-malignant, more in adult due to smoking or post-radiation. Juvenile laryngeal papillomatosis in infants is history of vaginal delivery. Multiple papilloma and 2 vocal cord. There will be a predilection to grow in the squamociliary junction with other nasopharynx and oropharynx. History of prolonged second stage of labor. Laryngeal papillomatosis is an acquired condition. It is recurrent respiratory papillomatosis, bimodal age occurrence caused by human papillomavirus 6 and 11. In adults, it will be single. Pre-malignant more commonly in adults due to smoking, and papillomatosis lesions become pre-malignant in adults due to smoking and post-radiation. Juvenile laryngeal papillomatosis in infants are seen. Juvenile laryngeal papillomatosis in infants seen with history of vaginal delivery. Multiple papilloma in true vocal cord. Multiple papilloma in true vocal cord. Multiple papilloma in true vocal cord. Multiple papilloma will be seen in true vocal cords. And if you have predilection to grow in squamociliary junction, there will be a predilection to grow in squamociliary junction. Alpha-interferon immunomodulator pegasisumab reduces angiogenesis. Pseudophobos intralesional. Alpha-interferon immunomodulator pegasisumab by vaccination for mothers is hypoxic and hoarseness or voice change of voice, dysphonia, aphonia. Hoarseness or voice change of voice. is this negative? What is the next line treatment? UPT is negative. Resistant resistance challenge test is also negative. Once the flower findings. Hoarseness of voice, change of voice, dysphonia, involvement of vocal cords can be due to infection, neuromuscular involvement, structural fusion, psychogenic and functional disorders. Involvement of vocal cords can be due to infection, neuromuscular involvement. So, involvement of vocal cords can be due to infection, neuromuscular involvement, structural fusions, psychogenic or functional disorders, structural abnormalities of midpoint of the membranous part of the anterior and the posterior to the junction of anterior two-third is membranous, posterior one-third is cartilaginous. Posterior one-third is cartilaginous. Main etiological factor is chronic voice abuse against diagnosis is laryngal and respiratory. Voice distance sensitivity section. Management of complaints. The model does not progress in accurate position. Voice distance is sufficient management. Pediatric pedunculate. The nodules are bilateral, unilateral, pedunculated, polypoidal mass. Nodule masses. Local products are calculated polypoidal mass with size less than 3 millimeters. Blood size will be more than 3 centimeters to more than 3 millimeters. Junction of anterior and the posterior ducal voice abuse. Certain episode voice abuse. Certain episode of voice abuse and unprepared larynx causes sudden hemorrhage of the submucosal tissue. Also two vocal cords. Chronic voice abuse inhibited teachers, singers, vendors. Unilateral pedunculated. Unilateral pedunculated polypoidal. Certain voice abuse in an unprepared larynx. Certain voice abuse in unprepared larynx causing hemorrhage into the submucosal tissue of submucosal tissue. Tests and facts. Laryngeal endoscopy is investigation. How do you investigate laryngeal endoscopy? And management of polyp would be excision by MLS, microlaryngeal surgery. Polyp is excision. Here we can do conservative management. If it does not regress, we can do excision. Okay, so that is the difference between polyps and nodule. Next, position of the patient of microlaryngeal surgery. The axis of the larynx should be brought along the axis of the mouth. So extension of atlando-occipital. This is called Boyle's position. Boyle's position or seven. It's called Boyle's position or Chevalier position or Chevalier-Jackson position or Barking dog position or Smithfield position. Boyle's position or Chevalier position. Boyle's position or Boyle's position or Chevalier. Boyle's position or Chevalier position. Barking dog position or Smithfield the morning head position. Position of the patient as the axis of the larynx should be brought along the axis of the mouth by extension of atlando-occipital joint. Atlando-occipital joint extension, flexion and cervical thoracic joint, which is how we bring the axis of the larynx along the mouth, bring the axis of the larynx along the mouth. So extension position of atlanto-occipital joint and flexor and cervicothoracic joint. This is known as Boyce position, Chevalier-Jackson position, Barking dog position, Sniffing the Mania position. Rosele will be extension at both atlanto-occipital and cervicothoracic. Rose position is both atlanto-occipital and cervicothoracic extension, and it is Rose position. If we are having extension of atlanto-occipital joint and flexion and cervicothoracic joint, this is known as Boyce position or Chevalier-Jackson position or barking dog position. Chevalier-Jackson, barking dog, sniffing dog. Now vocal cord cysts is voice or phonotrauma. Site is free edge of the vocal cords. Vocal cord cysts would be due to voice cause with the voice or phonotrauma. Free edge of the vocal cords. Diagnosis is by stroboscopy, which is attached to the flexible or rigid endoscope. Vocal cord fistula in the submucum. Free edge of the vocal cords. On a site, vocal cord fistula is another. Vocal cord nodule, vocal cord polyp, vocal cord cyst. Nodule, polyp, and vocal cord cyst. Vocal cord cyst and free edge of vocal cords. Free edge of vocal cords in the submucum. Free edge of vocal cords due to phonotrauma. Stroboscopy well convoluted. Flashes of light are given on the vocal cords which results in the appearance of individual waves of vocal cords separately. Flashes of light are given on the vocal cords which results in the appearance of individual waves of vocal cords separately. This helps to differentiate between the nodule, polyp, cyst distinctively. This helps to differentiate between the nodule, polyp, cyst distinctly. You cannot make him blunt your entire personality. This helps to differentiate. So there will be the individual stroboscopy chamber. They give flashes of light down, which is individual waves of vocal cords separately. You can differentiate between nodule, polyp, cyst. Management is excision by MLS. ഇതിന് നമ്മൾ എക്സിഷനാണ് ചെയ്യുന്നത്. Excision by microlaryngeal surgery in the Boyce position or sniffing the air position, morning air or barking dog. Barking dog, sniffing the air or sniffing the air. Okay, Boyce position. Now arytenoid granuloma is posterior 1/3. All conditions are more common on the anterior part except TB granuloma, which is more common on the posterior part. Most common except TB granuloma, everything else is more common. So arytenoid granuloma is seen on the posterior 1/3 of vocal cords. Arytenoid granuloma is seen on the posterior 1/3 of the vocal cords or vocal processes of the arytenoids or cartilaginous part of the vocal cords. It can be seen unilateral or bilateral. It can be seen unilateral or bilaterally. Etiologies: voice abuse, laryngopharyngeal reflex, and smoking trauma. If due to voice abuse, it will be a contact ulcer or contact pachydermia. Arytenoid granuloma ആണ് posterior 1/3 of vocal cords കാണുന്ന സാധനമാണ്. It is seen posterior 1/3 of vocal cords or vocal processes of arytenoids. So posterior 1/3 of vocal cords or vocal process of arytenoids or cartilaginous part of vocal cords. അത് unilateral ആവാം, bilateral ആവാം. Voice abuse, smoking, laryngopharyngeal reflex, trauma. Smoking, laryngopharyngeal reflex, voice abuse, trauma. Smoking, laryngopharyngeal reflex, voice abuse, trauma. If due to voice abuse or a contact ulcer, which is a misnomer, or contact pachydermia, arytenoid granuloma അല്ലെങ്കിൽ അതിപ്പോൾ voice abuse കാരണമാണെങ്കിൽ you can call it contact ulcer or contact pachydermia. This is an arytenoid granuloma which is on the posterior 1/3 of vocal cords or the vocal process of arytenoids or cartilaginous part of vocal cords, unilateral or bilateral. bilateral. If it is due to vocal voice abuse, it can be contact ulcer or contact pachydermia, laryngopharyngeal reflex and peptic granuloma. If it is due to trauma from intubation, it can be intubation granuloma. Intubation granuloma, if it is trauma from intubation, laryngopharyngeal reflex and peptic granuloma. Presentation, hoarseness of voice. Diagnosis is laryngeal endoscopy. Presentation, hoarseness of voice. Diagnosis, laryngeal endoscopy. Management, you have to give voice test. Management of the reflex. If there is no benefit, excision followed by injection of Botox in the thyroid muscle. Botox in the thyroaretinal muscle. Biopsy should be sent for histopathology to rule out carcinomas. Excision followed by Botox of thyroaretinal muscle. Rinke's edema site. Rinke space is the submucosal space of vocal cords. Rinke space is the submucosal space of vocal cords. Entire length of the vocal cord is affected. It is always bilateral. Etiology is chronic smoking. Chronic smoking, which is the predominant factor. Voice abuse, laryngopharyngeal reflex. Okay, chronic smoking is the most predominant factor for Rinke's edema. Chronic smoking, voice abuse. Rinke's space with the entire length of the vocal cord will be affected. Mucosa of vocal cord is not tightly adherent to the underlying vocal ligament. Lymphatic supply to the submucous is also poor, making it more prone for the development of edema. Lymphatic supply to the submucous is also very poor, making it more prone to the development of edema, which is also called smoker's larynx. Rinke space it is the submucosal space of vocal cords. Entire length of the vocal cord is affected. It is always bilateral. Chronic smoking is a predominant factor. Smoking cessation, management of reflux, voice, rest and speech therapy. Smoking cessation, management of reflux. Smoking cessation, management of reflux, voice, rest and speech therapy. There is no benefit, you can do reduction glotoplasty. If there is no benefit, you can do reduction glotoplasty. Incision on the upper surface of the vocal cord, reflection of the mucosa followed by suction of the epiglottis or excess mucosal tissue and reposition of the mucosa. Congenital anomaly, the epithelium of the true vocal cord is adherent to the vocal ligament in its medial or free surface. Pseudosulcus pneumosadana, where it is where the entire length of the vocal cord is affected, right? Sulcus volcanis. Vocal consider functional disorders in the muscle tension disorder. Muscle tension disorder, dysphonia, and voice fatigue, which occurs due to alteration in the tension of the muscles or formation due to stressful conditions. Hey Krishna, 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 Krishna.